you for the word. Hello, everyone. I'm Mattia from the University of Milan, Italy. And in this second part of the competition, the Megamind Contest 2024, I will present you a technique to optimize tissue around dental implant, both in post-extractive and in native bone implantology. Okay. We know that when a tooth is extracted in the first few weeks, the alveolus undergoes to cortical resorption with a consequent volumetric loss of both hard and soft tissues. In this contraction is maximum at 8 weeks after the extractive surgery. Immediate load post-extractive implantology allows the papillary and the gingival margin support to be maintained, and the provisional prosthesis helps us to protect the graft that is placed in the gap between the buccal wall and the implant. Immediate load is usually required from patient more and more over time, especially if we are talking about frontal areas. But let's face the problem of the posterior area. We know that in the molar and the premolar area, immediate loading becomes less effective and more risky technique for a loading problem, especially. For this reason, the clinician are motivated to look for new technologies in order to maintain the tissue architecture even in molar areas after tooth extraction. So the goal is always to guide the tissue and try to preserve the anatomy as much as possible. According to this logical flow, I will introduce you the spider technique, which is currently used in our clinical practice in the university since 2019, and we are currently analyzing it in our department with a prospective study. Here is an illustrative case. You can see the root of the element 45 is a patient who is affected of severe hemophilia type A. And requires the rehabilitation of the 45 element. Patient with this kind of pathology should go under a special treatment 1 hour before surgery in order to coagulate. Otherwise, they cannot coagulate because they miss a special, they have a problem in the coagulation phase. And they need to be observed time by time during the healing period in order to check if they have bleeding problems. Let's take a look at the CBCT study. The radiological analysis shows a preservation of the alveolar cortical, which is mandatory in order to do post-extractive implantology, and enough bone apically to stabilize a conical knife thread implant. Of course, we need implant with which can help us to give good stability. Even if no guided positioning is carried out, it is a good thing to plan and analyze the case in order to choose the right dimension of the implant and not to have problem in the surgical stage. In this video, you can observe the technique and the prosthetic flow of the profile management. We are luxating the tooth and extracting the root in an easy way. We didn't need to divide it. We will check the cortical wall, as I told you before. We drill, we place a 4x13, in this case, any implant, and we can connect the temporary abutment. We are gonna use a flowable composite in order to replicate the free gingival margin. And then we can connect the free gingival margin again with flowable composite and then fill in every gap in order to replicate the exact shape of the root. Removing the temporary abutment, we can fill the gap between the root shape and the shoulder of the abutment, not the shoulder of the implant, because we need to stay straight in the connective area. We're gonna polish as much as possible the surface of our customized healing abutment with different kind of burrs, one for the titanium, one for the resin. We fill the gap with Xeno because we want a low resorbable material in order to preserve the corticals as much as possible. And we can place with no stitches our healing abutment customized that replicates exactly the shape of the extracted root. From the control X-ray, the implant respects the plan. It is parallel to the premolar as it was planned, also if placed in a freehand way. And the healing abutment reproduces exactly the shape of the extracted root. Here you can check the healing after 1 week with no stitches and no bleeding, even in an severe hemophilic patient. After 3 months of integration, where you can see that the tissue architecture is well preserved, you need to give the technician the information to go directly to the definitive restoration. And this is one of the main points of this technique. The technician, with this technique, you will skip the provisional because you have already conditioned the tissue with the custom healing abutment. And for this reason, this technique is money saving, but more important, in my opinion, is time saving. This is the analogical workflow in order to individualize the transfer, but of course, this can be done also digitally, simply scanning the custom abutment in order to replicate the shape and give the technician the information of the transmucosal aspect. In the analogical workflow, instead, we need to connect the custom healing abutment with the analog, place everything inside a silicone, remove the custom healing abutment. In the third picture, you can connect the transfer, and adding the pattern resin step by step, you will have the exact shape of the custom healing abutment individualized inside the transfer. The individualized transfer is placed and provides a complete reading of the emerging profile. You can check if the pressure, and you just look for no ischemia. If no ischemia is present in the surrounding tissue, it means that the shape of the transfer, individualized, is the same that you have performed with the custom healing abutment. This can also be seen at the end of the impression phase. The technician will have a complete reading of the transmucosal aspect of the rehabilitation, avoiding the collapse of the tissue after the removal of the healing abutment. We know that when we remove the healing abutment, we will have a collapse of the tissue, and individualizing the transfer is a way to avoid this problem. Here is the delivery day. We will remove the healing abutment. We will place our crown, and you will see no pressure on the tissue. We torque the rehabilitation and 25 Newton as the manufacturer instruction are. We check the contact points, we check the occlusion, we adapt the occlusion in order to be correct, and we go directly to the definitive restoration. These are the tissue on the delivery day where a correct amount of soft tissue height and thickness is present, and this is fundamental to avoid any kind of resorption around the implant. And the final prosthesis where, according to the protocol, data on the pink and white aesthetic score are collected. We are now at 4 months in this picture where the stability of the hard tissue is also remarkable. And here we can see how this stability is maintained at the 2 years recall of this patient. So let's take a look at the preliminary results on 14 patients of 15 of this prospective study that is being finalized on custom healing abutment, and it will be under publication soon. Of course, all cases treated in premolar and molar area. Data collected are post-extractive discomfort, pain, swelling, and bleeding after surgery, pain on the delivery on the definitive restoration, because we know that when we go directly to the definitive with stock abutment, we have a pain problem for the patient, aesthetic evaluation performed with the FIP score, and marginal bone loss. Pain reported with the VAS score, the visual analogic scale, without analgesic, only in the first few hours was present, and almost zero bleeding and swelling at 1, 2, and 3 days after surgery. Complete absence of discomfort upon the delivery of the definitive restoration. Again, without passing through a provisional prosthesis, a maintenance of the tissue architecture and an optimal function. And this was analyzed with the FIP score, functional implant prosthodontic score, with results of 9 to 10 at the insertion of the definitive crown and at the 12 months control after surgery. Negative early marginal bone loss was recorded in all the treated cases in the first year, and we know how much is important that no early marginal bone loss occur in our rehabilitation. For this reason, we use this conical connection in order to place it under the bone and have no problem, because other kind of connection will give problem if placed under the bone level. So we discussed this technique in the post-extractive sites, and the answer is easy to understand. Is there a way to keep the advantages of this technique without customization in post-extractive implants, because it takes time, of course, and be able to use this technique also in native bone as well? Well, the answer to solve this problem is the introduction of the anatomical healing screw into our clinical practice. It's almost 4 months that we are using this kind of abutment, both in post-extractive implant sites and in native bone as well. And these are the first cases. We must, of course, choose, if we're talking about post-extractive implantology, the right size to support the tissue, because the fundamental thing is to support the free gingival margin that we do in the customization. We need to do it also with the anatomical healing abutment. So we need a kit in order to choose the right dimension. And if we are using them in native bone, we need to take into account bone peaks, because sometimes in native bone, we have bone peaks that do not allow the correct prosthetic sitting. In these cases, the easy use of bone profiler with their specific gold guide can help us to ensure the seating and solve this problem, especially, of course, in native bone, as I told you before. So, let's see a case of native bone and how to manage tissue with anatomical healing screw. You can see the horizontal contraction following the extraction on the molar in this occlusal picture. From the CBCT study, of course, we perform a CBCT study and we project the implant before. We can see that the volume is sufficient to place the implant, but from the previous photo, we can see that it is necessary to manage the tissue to ensure satisfactory aesthetic outcome, because we have a contraction and it's not bone, but it's more tissue. So the flap is designed in order to draw papilla with a C incision and to adapt this papilla to the anatomical chosen abutment. The implant is set in place in a prosthetically driven position. We are using pins and pathfinder to check the position of the implant step by step. The anatomical healing abutment is screwed, and it is possible to see immediately the capability of this screw to sustain the tissue. We are adding, to gain the missing volume, an epithelial connective tissue graft harvested from the palate, deepithelialized and placed in order to fill the missing soft tissue volume. It is then fixed to the primary flap with PGA 60 suture, and the same suture is used to close the flap, and it is already appreciable the volume gain through the graft and the anatomical healing abutment combined together. Hyaluronic acid, as shown in the picture on the right, can be injected in order to promote the healing in the secondary intention areas. After 1 week from surgery, the stitches are removed, and you can check the tissue healing in the distal part with the hyaluronic acid boost, close to the molar. And after 2 months, we have already conditioned the tissue, and we are ready for the definitive restoration. Also, in this technique, we need to give the technician the information of the transmucosal tissue in order to replicate them in the definitive restoration. And you can compare the defect prior to surgery and at the delivery day, where the soft tissue defect was treated with a soft tissue graft combined with the anatomical healing abutment. To resume, The spider technique can be applied to post-extractive sockets because you need a socket to customize the abutment. The anatomical technique can be applied both to post-extractive socket, but the clinician, need to choose the right abutment dimension, and it is for this reason more suitable for native bone. Both techniques allows you to maintain tissue architecture, are money saving, but more important, in my opinion, are time saving because you avoid the provisional. Of course, you need implants that are suitable for good primary stability in order to avoid complications. I thank you for your attention, and I hope that this short talk gave you an overview of the potential of these techniques to stabilize tissue around the implants and avoiding the risk of immediate loading in the posterior area. Thank you.